introduce themselves. And maybe Tyler, you could start.
Sure. Good afternoon, everyone. Thank you for everyone who's joining today and those may be tuning into our recording afterwards. My name is Tyler Slattery. I'm a senior program coordinator with our communicable disease team here at Washington County Public Health. And I'll punt it to Jonathan.
Hello, my name is Jonathan Gertz, and I'm one of the epidemiologists on the team. We have a few others as well. I will pass it along to Sung-Hae Do, one of our nurses.
Hi, my name is Sung-Hae Do. I am one of the city nurses. Pass to the Jenny.
Hi, I'm Jennifer or Jenny Robertson. I answer to both. I'm one of the communicable disease nurses. I can't talk today, but that's what it is.
Great. Sue, Kathleen?
Yeah, I can go. This is Sue Leong with Washington County Public Health. I'm also one of the communicable disease nurses. Thank you.
Great.
I'm Reese. I supervise communicable disease and data modernization. It's nice to see everybody. And I think Michaela, I'll pass it to you.
Hi, I'm Michaela. I'm a community health worker on the communicable disease team.
Great. And Callie?
Hi, everyone. I'm Callie with the branch supervisor for infection prevention and access to care.
Awesome. And I'm Bridget Monterossi. I'm a senior program coordinator in the infection prevention and access to care program. So welcome. We're happy to have you here today. And so I'm going to go ahead and launch a couple polls while Jonathan's getting his presentation up. He's our first presenter today. Let me get over to that. Okay. Technology is giving me some trouble today. Okay. Here's the first one. Pretty quick and dirty on that one. And then a very similar question. Okay, thank you. Jonathan?
Thank you. Now let's see if technology will cooperate with me.
Okay.
All right. Are folks able to see the opening slide, summer 2025? Still in summer. Yeah.
Yeah.
Sweet. Thank you. Thank you all for joining us, and thank you folks who are watching the recording. Technology go. To start, we're going to do a very brief review of our data that we received from you folks in relation to outbreaks. Looking back to 2024, this is something we showed at the last Learning Collaborative in April. We had 114 total outbreaks. The vast majority are those green, those COVID-19 outbreaks, with a handful of influenza, norovirus, and other outbreaks. This year to date, up to the 5th of this month, we are at 41 total outbreaks, not as green, not as much COVID as a proportion compared to last year. We're seeing more influenza outbreaks. We can largely attribute that to the peak of the flu season being in February. We also did see a couple different mixed outbreaks. We were fortunate to be able to, or the facilities were able to do enough testing to allow us to determine that there were multiple pathogens in several outbreaks. Looking back over the past couple of years, back to 2022, we see a dominance, majority respiratory outbreaks. This year, our total is maintaining that proportion of a handful of GI outbreaks to mostly respiratory outbreaks. Something to keep in mind is that compared to last year, we were at about 71 total outbreaks, and now we're at 41. So we're potentially going to see less outbreaks on this year. And also, since our last Learning Collaborative meeting in April, we have not had any GI outbreaks. So we've been able to keep that steady at 4. You folks have been doing a great job at taking care of your communities and keeping a very clean and tidy facility for the folks to live and thrive. We have one more poll question. Since we're on the topic of outbreaks, asking in which situations should a long-term care facility contact Washington County Public Health? You can select all then apply. Or multiple.
Okay, just a few more seconds and then I'll close the poll.
Thank you. I think I've seen responses or incoming responses slow down. So all of these are situations actually in which you can contact Washington County Public Health. A couple of them are newer compared to some older guidance that we had. And on the next page, oh, technology, please. There we go. We have a listing of all the different situations, specific situations or scenarios in which we would like to hear from you, our partners at these long-term care facilities. In the case of GI illness, it's 2 or more residents or facility staff with GI illness within 3 days of each other in the same cohort. So that could be the same unit, the same floor shift. They could go to lunch together. They could be go on social outings or other like exercise activities in the same group. It could also be a single case of GI illness with bloody stools that cannot be explained by another non-infectious cause. So if we're not sure what it is, but someone's experiencing bloody stools, we would like to be alerted to that, and we can start working together to support this individual. In the case of respiratory illnesses, we're concerned about 3 or more confirmed or presumptive cases of influenza, RSV, or COVID-19 affecting 10% or more of your staff or residents in a 10-day period, and this is also in the same cohort. Could be that your facility completely mixes, so your whole facility is a cohort, or there could be smaller cohorts within your facility. We're happy to meet and have kind of a review of your facility's layout and help identify if there are smaller cohorts than your entire facility. We'd also like to hear if there's a chest x-ray of confirmed pneumonia in 3 or more residents, unusually high absenteeism by staff complaining or of related symptoms, 2 or more residents or staff with high fevers that cannot be explained by another known issue, and any hospitalizations or deaths related to a current outbreak, or 2 or more hospitalizations and or deaths among residents or staff with severe or similar symptoms. Before I go on, anyone have any questions about any of these or when to contact Washington County? And throughout the presentation, I have links to resources and guidance that should work when we share out this presentation. If they don't, please reach out, or if you have questions about any of the guidance, please feel free to reach out. But this guidance is 2 pages, so it also has the when to contact. In addition to the when to contact Washington County, it has information to include in the initial report to us, guidance on how to prevent other residents and facility staff from becoming ill, what to expect in terms of reporting and updates to us during the outbreak, and a flow chart that explains this process in a visual manner. Something that we would like to improve is to be able to have a clear record or understanding of the vaccination coverage at your facilities. You folks have been doing a fantastic job at keeping track of all residents and staff, and then also taking a closer look and supporting those folks who are ill or maybe reporting illness. But vaccination is something that we like to have at intake, but oftentimes isn't available. Another poll question. What is the most common cause of gastrointestinal illness in the United States?
Okay, just a couple more seconds and then I'll close it.
Thank you, Bridget. The correct answer is, which a majority of folks got, is norovirus. In the US, causes about 77 million instances of GI illness. Very, very aggressive symptoms that do fortunately last only up to a few days typically. But people can experience very aggressive or violent repeated instances of vomiting and diarrhea. People can experience pulled muscles, muscle strain, slip ribs, physical discomfort just because of the amount of retching and just having to expel. Can be extremely difficult to contain as well. It only requires a small amount of the virion to pass along and infect somebody else. Does transmit via the fecal oral route. This is a diagram we shared back in April, where feces can find its way to another person by water, food, contact with contaminated surfaces. There is no vaccine. Education of residents and family or other visitors is key in helping prevent the spread when you know what's happening. There is a training that I believe I pulled from a CDC resource page that is on YouTube in English and Spanish. Might be something that's useful for onboarding or to share out to your community when you notice any GI illness. It's also very important with norovirus to follow the guidance for disinfection because it is hardy outside on surfaces and it only takes a small amount of this pathogen to infect another person. The EPA provides guidelines. I have, I think, multiple links to them in this presentation, and they're at the top of the page when you do an internet search. The additional key to disinfection is to use hand soap instead of hand sanitizer. The hand sanitizer isn't sufficient in cleaning a person's hands. Treatment for norovirus is limited to hydration, rest, management of other symptoms. Antibiotics will not help. And issue with norovirus, because there are so many different variations of norovirus, there's a lot of resilience that a person gains after being sick with norovirus. They could be sick, recover, and then be infected again with noro of a different variety. All right, now thinking back to outbreaks, which pathogen is responsible for the most outbreaks at long-term care facilities in Washington County? Responses have slowed. It is COVID-19. A quick look at the region in terms of respiratory illness, specifically COVID-19, because that's what's active right now. If we look at the orange line, this is the test positivity for COVID-19 in Oregon through the current season of 2024 back to October up through 2025. We see that it's tracking pretty closely right now to that orange line. That's 2 years ago, 2022-2023 respiratory season at currently about 9%. What we have seen in the past couple weeks is a revision of the test positivity, and the revision has been to a higher test positivity typically. So we're getting test information a little later, or getting additional testing information and incorporating that into these statistics and revising them. So we may be looking at currently kind of getting into a summer wave of COVID-19. We have seen outbreaks in the area related to COVID-19 recently. If folks have respiratory illness, this should be higher on your radar. Because of the limitations that we're seeing with test positivity, a lot of folks end up testing at homes. They may not report their positive test results. Wastewater has become a more helpful tool or reliable tool in seeing what transmission looks like in different communities. This is a map of the US, and the different shades of blue indicate the different levels of COVID-19 detected in wastewater, with lighter colors indicating a lower level of viral activity. Oregon's lower, but our neighbor to the south, California, is experiencing higher activity, and we are surrounded to the north and east with moderate activity in Washington and Idaho. And here's Oregon's dashboard that has all the different wastewater sites across Oregon. Over in the towards our area, we see a decrease. I believe that's the Beaverton or Hillsborough site, and plateau in Forest Grove at the moment. Given regardless, we're across 96% of wastewater treatment facilities. They are detecting viral activity. So it is present, it is circulating. It may be decreasing or plateaued in our immediate area, but down in, I believe that's McMinnville is the first little orange pyramid, and then out towards the coast and east towards Pendleton region, we are seeing increases. We can also look towards emergency department visits to get an idea of how active different pathogens are in the area. This is looking at our Washington County, along with Multnomah, Columbia, Clatsop, and Clackamas counties. We see that COVID-19 is the primary respiratory illness since driving emergency department visits at 0.6%. Influenza, very little activity, 0.1%. We haven't seen a lot of influenza activity recently. OHA will alert all of us, and we'll alert each other when they start to see that positivity increase and get to that point where we need to declare respiratory season. And currently there is no RSV activity, at least in emergency departments. Looking at COVID-19 associated hospitalizations in Oregon, the age group that is most impacted are those folks who are 65 plus years of age or older at 6 per 100,000, followed by infants and children, sadly, at ages 0 to 4 at 2.3 per 100,000 individuals. Oh, my apologies for the typo there. But the third most impacted age group by COVID-19 hospitalization are those folks in the 50 to 64-year-old age range. There are a number of different resources that are still active. I appreciate them. Some links may have been coming off, others on. But for this next section, I've tried to put together resources that are still active that you can still access that are geared towards your facilities and your communities to help prevent and mitigate respiratory outbreaks. The key is vaccination. Thank you, Ryan, for joining us and giving your presentation on vaccination clinics. The other tool that is extremely helpful is monitoring for symptoms, checking in with your community residents and staff included, and all staff. We are interested in the health of your nursing staff as well as your administrative staff, your housekeeping, food services. And what is also helpful, especially at this time, we're seeing only moderate increase in COVID-19 activity with limited influenza and RSV activity. is to take inventory of what resources you have available, including masks and other PPE, making sure that you have enough equipment or maybe pre-assembled kits even for your staff to utilize when there is illness detected or an outbreak occurring. Take stock of what kind of testing your facility can perform. Some facilities are able to test all of their residents and all of their staff multiple times a week, as well as send staff home with tests that they can take if they develop symptoms while on their weekend or before coming to work or returning to work. Prophylaxis is a extremely helpful tool to have, especially with the community that you folks are supporting, making sure that you have a supply available, or more often a provider that you can work with to, or pharmacy to access this prophylaxis. Air circulation, especially with respiratory viruses, can be very helpful in reducing the impact and risk to your community. This can be as complex as bringing in multiple air purifier units, or deploying them strategically within rooms that for folks who are ill or in common spaces. Cracking a window open can be extremely helpful when the weather allows for it. Also using the exhaust fans throughout your facility, so kitchens, bathrooms. Some guidance suggests keeping those on constantly during an outbreak situation so that exhaled air is just constantly being removed from the environment. And then contact us if you have any questions at all that could be related to what can we do to prevent this, or quick update on kind of the state of respiratory illness circulating in the area. When you do identify illness or an outbreak situation, triage and control is a key aspect in limiting the impact on your community. Screen for symptoms for staff and residents. Ask residents about their symptoms whenever, at least on a daily basis, and create opportunities for the residents to reach out to your staff. Make sure they feel comfortable in sharing that they are experiencing a cough or sore throat, or especially wheezing. Encourage reporting of symptom. Also, make sure to send sick staff home and do not allow them to return until they've completed or fulfilled the recommendations for return to work. Isolate sick residents if possible, as much as you can. If there are common eating spaces and you still want to utilize those, space out when people go to eat. So have multiple shifts of breakfast, lunches, dinners, so then there's as few people as possible in these common spaces. Make sure to be able to send out for medical evaluation if necessary, and contact us, please. Here's a bit deeper look at or quick look at specific resources. The Oregon Department of Human Services has this resource page for long-term care facilities that may be one of hopefully or possibly several spaces that have updates on any policies or guidance or rules in relation to federal regulations or legislation. CDC has infection prevention resources for multiple specific pathogens, as well as a viral respiratory pathogens toolkit. So this may be something that is helpful to review before our respiratory season reaches us. And here are some other resources that are still active from OHA and CDC, including resources for norovirus, which we still have seen throughout the state of Oregon, and they've been at long-term care facilities, unfortunately. As I mentioned earlier, we haven't had any GI-related outbreaks since April, but they have been around Washington County. And that is all I have for today. Any questions or comments from folks? Thank you for your attention, and I'll pass it along to Ryan if my technology allows me to get off.
Yeah, thank you. I'll go ahead and introduce Ryan. Thanks, Ryan, for being here today. Ryan Frick is a population health epidemiologist with the Aging and People with Disabilities program at the Oregon Department of Human Services, focused on infection prevention and quality improvement projects. And I'll turn it over to Ryan.
Great. Thanks, Bridget. Thank you, everybody. Glad to be here today. Thanks for having me. Are you able to see my slide deck? Is that kind of okay? Great. So yes, thanks for the introduction. My name is Ryan Frick. I'm a population health epidemiologist for the Aging and People and Disabilities program at ODHS. And I'm here today to talk about our on-site vaccine promotion program for long-term care facilities in the state. So I will advance the slide deck. Just a short introduction to our team. So I work for the population health team at APD at ODHS. And our team is focused on safety initiatives and improving outcomes for our APD consumers across care settings, from in-home settings to our APD licensed NIFs, RCFs, and assisted living facilities in the state, adult foster homes. And we are really focused on quality improvement projects kind of across the safety spectrum. I focus on infection prevention. So I'm here to talk to you today about our on-site vaccine clinic support program. I'm also running an antibiotic stewardship learning collaborative for our long-term care facilities in the state that you may have heard of. So that's really our team's focus. So our on-site vaccine clinic support program was launched last October 1st, 2024. And it is open to all of our APD licensed nursing facilities, assisted living facilities, and residential care facilities in the state. This program's history kind of begins in early 2024. We had some funds allocated that were meant to address declining vaccine rates among staff and residents of our licensed long-term care facilities, focusing on, like I said, NIFs, ELFs, and RCFs. And we essentially arose at the program that I will share with you today. And like I said, that launched on October 1st of last year. And really, we are matching interested long-term care facilities with a community pharmacy that will come and provide an on-site clinic for respiratory season. And really, that's kind of where this began. So the goals of our program, like I said, are to increase vaccine rates amongst staff and residents in our licensed care facilities. And really, we're accomplishing this by incentivizing community or independent pharmacies across the state to go on site and provide these clinics for interested facilities. We wanted to increase access to COVID and flu vaccine in our licensed facilities in rural zip codes and frontier counties. That was kind of our initial goal, and that has expanded to include all of our facilities now being eligible. And really, we wanted to support our community pharmacies that are really well-versed and passionate about providing some of these enhanced preclinic services to our facilities. So whether that's helping with consent at the facility level, helping with billing, and then helping to really schedule the clinic date and then coming on site and providing vaccines. So really wanted to incentivize our community pharmacies to participate and then kind of pass some of those incentives onto them. We have a significant amount of funds still available for this, so we are going to be providing this program through the 25-26 respiratory season. There may be support beyond that, depending on demand this year. So really our focus is on respiratory season now. So we've had interest in this program throughout the summer. So our facilities had access to hosting a COVID-specific clinic if they had wanted to this summer. But our real focus is respiratory season, and I'll get into more details here shortly. So really, we began this program last September. And really, it began just by entering into an IAA, or an interagency agreement, between our APD program at ODHS and the Oregon Prescription Drug Program at OHA. And they really are our strongest partner. And this program is really a kind of a co-production, if you will, between our program at APD and the Oregon Prescription Drug Program. So basically how our program works is I have directed recruitment to all of our facility administrators, roughly 600 of our facilities in Oregon who are eligible for the program. And there is a survey that collects basic information from the facility, contact information, if they're interested in a clinic, how many estimated participants there would be. And then from there, that information is routed to our OPDP partners, who then match the interested facility with a contracted pharmacy in the general service area of that pharmacy. And I'll get into our contracted pharmacies in a bit. We have around 15 across the state. We have statewide coverage. Any interested facility is eligible to participate, and it would match with a contracted pharmacy. Like I said, as of yesterday, all of our 600 or so APD licensed long-term care facilities in the state have been contacted for potential participation in the program. Initially, we wanted to focus and kind of extend these resources to our kind of most vulnerable or at need facilities, facilities in frontier counties, rural zip codes who had never had access, maybe, to an on-site clinic. From there, we expanded to all of our facilities. That was on December 1st of last year. And that's when all of our LPHAs were contacted and alerted to this opportunity. And we were able to extend this agreement through this year. So we put together a new package of incentives for our contracted pharmacies on April 1st. So kind of year 2 of the program began on April 1st of this year. And like I said, we'll really be running through April of next year. Funds are available on a first-come, first-served basis. We've had pretty robust interest in the program this year. Last year, we hosted 30 clinics as a result of this effort and this program. And this year, we're already working with around 75 facilities who are interested and are coordinating clinics with a pharmacy. So we're excited about that. Significant funds still remain, but it is available on a first-come, first-served basis. So like I said, I'm the main point person on the APD side. So I'm in charge of kind of recruiting our facilities, sending out those emails, and kind of facilitating the environment. From there, OPDP, they have our pharmacy relationships, and they will actually match the interested facility with the pharmacy and kind of give that more handoff, provide resources to the facility. And then from there, the pharmacy will work with the facility to schedule a date, to gather consent forms, and to go on site and provide a clinic. So facilities are able to opt into the program via a survey. That's a micro form survey that is sent out via email to all of our facility administrators. We will be providing resources after the presentation today that has that information about how you can opt in, benefits of the program, what is covered. That'll all be sent out today for anybody who's interested. Like I said, you may have heard from me via email. I send out reminders roughly every 3 weeks. This is really our crunch time right now as we've gotten into August and we're preparing for respiratory season. So all of that will be sent out following today's call. That's a very, like I said, easy survey, collects basic information. It allows facilities to opt in when they're ready to schedule a clinic. So I will go over quickly some of our benefits and incentives of the program. Like I said, we have roughly 15 contracted pharmacies that contract with the Oregon Prescription Drug Program. And from there, they're able to receive an incentive, and that's really what our program funds are paying for. Like I said, we are trying to incentivize community pharmacies. It's a challenging environment for our pharmacies, and we have declining access statewide for our APD licensed long-term care facilities. pharmacies are having difficulty being reimbursed for the cost of doing business, essentially. So this is meant to support our pharmacy statewide who provide these services for our long-term care facilities. So the majority of the funds are going to our pharmacies through a series of incentives. The pharmacies receive incentives per patient, and there's kind of a gradient, $40 in frontier rural facilities, 30 in urban, and then we have a $45 per patient incentive for our critical access pharmacies. The program covers COVID-19 and flu vaccine at each facility's clinic. And then there's also an incentive for RSV and pneumococcal this year that was added this year. So pharmacies are reimbursed on a per patient basis for those 4 vaccines. And then this year we also instituted a fixed fee mileage incentive. So the pharmacies are receiving $300 for driving up to 5 miles, $600 for driving up to 25 miles, and then $1,000 for over 25 miles. So that's kind of how we're directing the funds to our participating pharmacies. Like I said, we have pretty robust participation from our pharmacies at a state level. Any interested facility statewide is going to have coverage. Geography is not a limitation for us. So we've had great participation from our pharmacies. We have 13 currently in contract. Some of those pharmacies have multiple locations that are directing services from. So it's more like around 20 buildings. Here is a list of our currently contracted pharmacies statewide. So in Washington County, we have 2 pharmacies who the state had strong relationships with from the public health emergency in the last few years. We have LaCare Pharmacy and Pharmacy.com in Multnomah County, who are being matched with facilities in Washington County currently. We also have Safeway, who kind of acts as a backup vaccinator statewide. We're in contract with 6 Safeway locations, so they have been a strong partner in kind of filling in some of our geographical gaps. I believe we've had 6 Washington County facilities who have opted in and we're working with to get scheduled. And like I said, they're being matched with LaCare and Pharmacy.com in Multnomah County. So kind of a summary of the program benefits. Our program not only incentivizes community pharmacies to come on site, we've also have a kind of a few benefits that are unique to our program and kind of make us a unique partner if a facility needs on-site vaccine services. So we are covering uninsured staff and residents. So I guess I should basically reaffirm that we are covering residents and staff in our APD licensed facilities. So residents and staff are eligible to participate on during these on-site clinics. We are covering uninsured staff and residents during these clinics. So that might include anybody who's uninsured or who has out-of-network insurance for that particular pharmacy. So the pharmacy has a pathway where they can bill for uninsured staff and residents. So that is a strong benefit of our program. As I said before, we're incentivizing critical access in community pharmacies to provide on-site services. Our program also eliminates a minimum that is typically required for on-site services at our facilities. So previously, if you worked with kind of a chain commercial pharmacy, they would typically require 25 vaccinations per hour per pharmacist on site. Our pharmacy does not have any established minimums. So we've been able to serve buildings that might have 10 beds at a residential care facility. So we've gotten rid of those kind of established minimums. So covering uninsured staff and residents, no minimums for on-site clinics. And then we really are trying to kind of match our facilities with pharmacies that are committed to working with our long-term care facilities in establishing a date, getting consent forms, and really working with the facility to make this as smooth a process as possible. So those are the benefits of our program. I mean, like I said, this is available on a first come, first served basis. Once our funds are expended, it's kind of unknown with the environment we're dealing with now. I don't have an established funding source beyond what we have now. But like I said, we do have significant funds remain, and we're working with almost 75 facilities right now. So I'm hoping that facilities that participate in the program will kind of leverage that relationship that they have with their matched pharmacy, and it can kind of leverage that relationship for services that might be required in the future. So that is the extent of the program. Like I said, I have a one-pager that we put together that kind of succinctly captures the benefits of the program and how to opt in and how to work with your pharmacy. And then there's also an FAQ document that I have with additional information on the program. And like I said, we've gotten into August, so we're really kind of in crunch time in trying to get facilities opted in and scheduled. Like I said, we are urging any interested long-term care facility to schedule as quickly as possible, as we have a declining access across the state from the pharmacy side. So scheduling as quickly as possible is something that we are urging facilities who want to take part in the program to do. So my contact information is here. Like I said, we'll have those resources go out. And please let me know if you have any additional questions. So yeah, we're happy to work with anybody to get scheduled. So thank you again for having me today, and I will take any questions.
Thank you, Ryan. Really appreciate the work that you're doing.
Thank you.
It's great. Okay. Any last comments or information that the Washington County team wants to share before I wrap us up? Okay, great.
I guess I'll just say thank
Oh,
you all
sorry.
for joining today, and thank you for Ryan for presenting. It was really helpful information, really great work that you're doing. Appreciate to see it. So, and for facilities on the call, just please don't hesitate to reach out to us with questions or, if you're seeking any guidance around communicable disease or outbreaks at your facility. Thank you.
Thanks, Tyler. Yeah, we're always here to help, and we appreciate getting your calls. So we are offering CEUs for this session, and for those of you who attended, I will be sending out those certificates tomorrow. We will also follow up this meeting to all invited participants with the presentations and the resources that were shared, and so those should go out this afternoon. And we appreciate you being here. This session was recorded, and it'll be housed on the long-term care facility page of our Washington County website. So I will also be sending that out in a subsequent email once that is live on our website. We really appreciate you attending, and thank you all, and have a good day.
Thank you.
Thank you.
Thank you.